I'm Dr. Angie Boyd, and I'm a professor at Northern Kentucky University. And the presentation today is going to be on immersive preparation, leveraging virtual reality to bridge the gap between classroom learning and clinical practice and occupational therapy education. And I'm going to take my video off now so you can see my screen. Okay. So, I'm going to talk a little bit about our agenda, and we're going to look into a Kahoots quiz and just kind of a fun facts on what we might or might not know about how virtual reality is being utilized in higher education today. Look at our learning objectives, what I discovered from the evidence, the various types of virtual reality that we utilize here in our NKU program, and then any final tips and takeaways that maybe I may have found, or any questions that you may have can be emailed to me as well. So let's complete this Kahoots. Okay. So this Kahoots is just kind of what's going on out there right now with virtual reality in higher education, and maybe how it's being used in higher education and what students are learning from it. So just if you know the answer, see if you know them, see if you get them right. Just kind of take the little quiz along with me. I'll tell you the answers after each one. Let's get started. So the first one, students retain up to 90% of information when learning through VR experiences, compared to just 20% from lectures. And this answer is actually true. The second one, medical schools are using virtual reality to let students perform virtual surgeries hundreds of times before touching a real patient. And this is also true. Some programs report that virtual reality trains students perform initial procedures 230% faster than traditionally trained peers. And this is true. And the questions are duplicated, so I'm just skipping the first slide for each question. Students have used virtual reality to time travel. An example is so this one's all of the above. History students can walk through ancient Rome, explore the trenches of World War I, witness the signing of the Declaration of Independence. Language immersion. Language immersion virtual reality programs can drop students into virtual markets in Tokyo, where they practice cultural immersion. This is true. Virtual reality users report feeling somewhat less confident speaking in real-world situations after some virtual interactions. And this is false. Medical and social work programs use virtual reality too. So think about social work programs, medical programs specifically using virtual reality too, and that is aid students' experience with disabilities and mental health conditions. Companies like Walmart train employees using virtual reality for this one was surprising to me, but it is all of the above. Black Friday crowd management, best practice customer service, reducing training time by 75%. Haptic feedback suits allow students to feel the texture of ancient artifacts. This is something I was not familiar with either, and this is true. Amazing what it can do. Psychology programs use virtual reality exposure therapy to confront virtual spiders, heights, or public speaking scenarios. Okay, so, and that is our Kahoots. And we will go back to our presentation. Okay, so our learning objectives today are to analyze the various types of virtual reality technologies and their distinguishing characteristics within healthcare contexts. Evaluate virtual reality platforms commonly utilized in occupational therapy practice and education, including their clinical applications and specifications. Design evidence-based strategies for integrating virtual reality platforms within occupational therapy programs, and critically assess current research evidence and real-world applications of virtual reality platforms in occupational therapy practice. What is reality? What we call reality is a construction built from partial information, and every perception can look different at a micro level. Mine can be different than yours can be different than your neighbors, your peers. So we know that the eyes take in light, the ears receive vibration, the skin senses temperature and texture, and the brain interprets all these things. That interpretation is what virtual reality actually taps into. One second, please. Student knock on my door, so I was just prepping for that. So our perception of reality really emerges from how our brains process that sensory input that I just spoke about. We receive those fragments of sensory input from our eyes, sound waves through our ears, and pressure and heat through our skin, as I said before, and then we interpret that. So this interpretive process is what is exploited by the virtual reality. So you want to consider standing at the top edge of a building. Rationally, you understand you're sitting down right now. You possibly could be standing, but you understand where you are. But if you think about that and you close your eyes, so you try to align yourself with the visual depth and the auditory cues of standing at the edge of a building. You try to visualize that with a new visualization of different spatial surroundings. And maybe give yourself a wind gust, or you start to think of things that could be going on from an environmental standpoint, and then your nervous system would react to that. Hypnotics taps into that as well, that process. So virtual environment doesn't require perfect visual fidelity to captivate us. It must maintain internal logic. So when our brains receive the sensory information that remains internally consistent, and when the world responds predictably to our movements, something remarkable happens. our minds can accept that new illusion and we become present in that virtual sense. What is augmented reality versus virtual reality? So augmented reality involves using a device to transfer information into your space. So when you think of augmented reality, you want to think of something like a see it in your room feature, like you might find on Amazon. Okay. A virtual reality involves leaving your space and entering a new one. There's three types of virtual reality: the non-immersive, the semi-immersive, and then the fully immersive. Okay. The non-immersive is something like a video game. And then the semi-immersive is like a virtual home tour. And then a fully immersive is full participation from the individual and in that they can touch, they can feel, they can explore, and they have feedback in real time from those interactions. I can't help when I think about virtual reality and one of the experiences that I've had, and many of you possibly could have had as well, was the Avatar ride at Animal Kingdom. And there's a few other rides now that are realistic in that virtual reality sense. But you literally are in Animal Kingdom in Walt Disney World. I'm sorry, not Universal Studios, in Walt Disney World, Animal Kingdom. And you climb aboard this motorcycle-like object. You get strapped into your seat by an attendant to make sure it's secure. Your bike starts to breathe, like literally breathe. It expands and contracts. You start hearing the breath sounds. And then you realize you're actually riding your own banshee, a flying dinosaur. And then everything in front of you, from a visual standpoint, goes black. You can't see it all, but you can feel your banshee jump as the wall in front of you changes and the whole new universe of Pandora is seen and appears. You watch and listen to the sounds of the ocean, the waterfalls, the flying birds rush past you. You're soaring through the air on this banshee, and you see an enormous whale shoot out of the water below you and nearly hit you as it elevates, turning in the air and flipping back down. And then you fly off this huge cliff, almost directly into the water, and it takes your breath away. That was probably one of the most immersive experiences, fully immersive virtual reality experiences I have ever had. I wonder if you all have had similar one. And that is what I would like to give to our students, that opportunity to be fully engaged and learn from something outside of a textbook. How is virtual reality useful in OT education? It's realistic, it's scenario-based, it has an element of controlled, safe environment, and it's structured. So you can use virtual hospital rooms. You can perform simulated home visits. You can have a classroom that is virtually managed. You can have case-based scenarios. You can have professional setting immersions, such as one of the platforms we're going to talk about is when you can actually swap bodies with your patient or with another interdisciplinary professional. And it's a controlled, safe environment where high-risk procedure practices will enable students to learn without making without the real world consequences, excuse me. And using virtual reality, you're also able to structure your skill training. So you can start with a part task trainer and you can work the student up to more a professional relevance to clinical education and clinical reasoning. Immersive virtual reality technology, or IVR, addressed our placement needs. This is why we started using it. It enhanced learning outcomes in a way we never thought possible, creating an enriched educational experience. It engaged students and facilitated that interdisciplinary connection. And we actually launched our occupational therapy program during the pandemic, which provided a whole new unique set of challenges. We embrace the opportunity to innovate and grow through the use of virtual reality. And like many emerging programs, we discovered that securing quality fieldwork placements sometimes became difficult, especially particularly those level one experiences. And that presented an exciting puzzle for us to solve. How are we going to enable these students to build on these skills without having an actual level one placement? So this presentation examines how virtual reality fieldwork education bridge this gap, preparing our students for more effective real-world clinical environments. And we will evaluate the VR solutions that we utilize here and assess their practical integration into occupational therapy curriculum or occupational therapy training in general. So one of the articles that we reviewed in completing this presentation and development of our VR program was Craig and Kay 2023. This was a systematic review looking at 332 immersive virtual reality studies in higher educations. And the key finding, with close to 10,000 participants, showed enhanced skilled acquisition and improved learning outcomes for disciplines requiring hands-on experiences. It also revealed students reported increased motivation for engaging with VR activities, which directly affected overall department costs due to one-time purchase annually, which we have built into our student fees. The virtual reality aligned with real-world applications uses scaffolded instructional design, maintains adaptive implementation approach, which kept students engaged and motivated in learning. And sometimes this looks like if we go over a particular skill with our VR equipment, we'll go back to the students and say, what more do you want to learn, or what more do you want to see, or what would you like to practice further and gain further knowledge on? And then we can build on some of those experiences using our devices. Another study by Redinati, 2020. This was a systematic review of immersive virtual reality applications for higher education. It had design elements, lessons learned, and a research agenda based out of the Journal of Computers and Education. It found that it was particularly valuable in medical school education because it afforded students in the medical program and medical professions in general a risk-free environment. It showed these professionals were better prepared through this risk-free practice and repeated practice of more precise procedures under a simulated pressured environment. The immersive nature of virtual reality increased student engagement and motivation, leading to overall deeper understanding of the scientific concepts. And the practical applications were the most commonly used VR augmented reality higher education research is simulated-based learning, where students complete scenario-based tasks. Other approaches included digital learning environments, virtual field trips, assessments, and virtual labs. And in this one in particular, those case-based scenarios were the most beneficial. Virtual reality related to the OT process and domain. So occupation-based interventions for ADLs and IADLs. Virtual reality technology enables therapists to create controlled, repeatable environments for practicing essential life skills. Clients can rehearse basic ADLs like bathing, dressing, and grooming, while IADL tasks such as cooking, medication management, shopping, and financial management can be safely simulated. This allows for graduated practice with adjustable complexity levels and immediate feedback. It is also related to our OT process and domain through social participation enhancement. VR facilitates social skill development and community integration by simulating real-world social contexts. Clients can practice workplace interactions, navigate public spaces, participate in virtual support groups, or rehearse challenging social situations like job interviews or social gatherings, also like IEP meetings or interdisciplinary rehabilitative meetings with patients and families. This is particularly beneficial for individuals with autism spectrum disorders, social anxiety, and those recovering from traumatic brain injuries. It also aligns with our performance pattern development and modification. Virtual environments support the establishment of healthy habits, routines, and role adaptation. Clients can practice time management skills, develop consistent daily schedules, and explore occupational roles in a risk-free setting. It allows for repetitive practice of performance patterns while providing data on consistency and improvement over time. It also looks at things like client factor targeting, specifically addressing underlying physical, cognitive, and psychosocial components that support occupational performance based on those specific client factors. It also connects with our performance skill enhancement across motor process and social interaction areas, as it provides opportunities to develop and refine observable actions that compromise occupational performance. And motor skills like posture, mobility, and bilateral coordination can be practiced through movement-based VR activities. Process skills such as sequencing, organizing, and problem solving are enhanced through virtual task completion. And then it also connects with our context modification through environmental simulation, as it creates customizable physical and social environments that can be systematically modified to support therapeutic goals. So such things like environmental factors of lighting, noise level, spatial layout, and social density can be applied to match client needs and gradually increased and modified to ensure that the levels of complexity are realized by the student. So this supports kind of that just right challenge principle while ensuring safety and allowing for multiple practice opportunities without those real world consequences. So the most common IRV applications used in our OT curriculum are Simulcase. We have an Oculus device. We actually have two Oculus devices. We use the Body Swaps platform, and we use the Animage table. So we're going to go through each one of the applications. Talking first about the Simulcase virtual platform. This is very familiar to most OT programs. It's a competency-driven online education through virtual simulations and interactive videos that develop real-world skills. Students who completed simulated-based level 1 fieldwork utilizing Simulcase performed equally well on level 2 fieldwork evaluations compared to students who completed traditional in-person experiences. This was a big study that really solidified that use of Simulcase. We don't just use Simulcase, we also use our simulation center here on campus, as well with standardized patients from the community. With that combined, in combination with Simulcase case-based scenarios, we're able to kind of pinpoint those targeted outcomes that we want the students to meet. So how we use Simulcase, we use the part task trainers specifically for multiple line management, interdisciplinary collaborations, and obtaining an occupational profile. And additionally, students can complete standardized assessments, choose an intervention, and get real-time feedback on their performance and learning and assessment modes. So the evidence on Simulcase, as I said, is there. This study by Matilda, Martin, and Dia Lewis examined 29 occupational therapy students' satisfaction and perceived learning outcomes using the Simulcase platform for level 1 fieldwork, comparing their experiences before and after the simulation. And the key findings were significant improvements in 2 areas. Debriefing and reflection scores increased significantly. Clinical reasoning scores increased significantly, and clinical learning showed strong trends but didn't reach statistical significance. And then the practical applications, there was a structured reflection sessions with faculty were the most valued component, providing opportunities for guided self-reflection and immediate feedback. So this is why we also complete that debriefing process. This is just essential for the students to see maybe opportunities for growth, potential challenges they might have moving forward into a more difficult case, for example. But that emphasis on debriefing is very important. Here is just a brief video on SIMU case.
Today, we're going to be taking a look at Kelly. Then we'll click Start, and then we have the option to start in learning mode or start in assessment mode. Learning mode provides you with feedback the entire time you're completing the case. With assessment mode, you don't get any feedback until after you submit the case. Let's start in learning mode. Now we're on our Getting Started page, and we can show our clipboard. The clipboard's going to be where all the information we collect during a case gets stored. It's also going to have our referral information. Here we see that Kelly's 7 years old. She's been having difficulty learning to read. She's in the 2nd grade at a private school. Her mother is seeking additional information and is requesting a comprehensive speech and language evaluation at your private practice. Across the top of the screen, you'll see the areas that we're going to be working in: case history, collaborators, hypothesis, assessments, diagnosis, and recommendations. When we complete all of these areas, we can submit our case and we will receive an overall competency score. In order to count these for clinical clock hours, you do need to receive a 90% or greater. To the left of each of the headers are progress meters. These progress meters will fill up as we make reflective decisions or select reflective questions to ask our caregiver, client, or other collaborators. So let's start our case study, and then we'll hear from Kelly.
Hi, my name is Kelly and I'm 7 years old.
So we want to start with our case history. So we're going to interview Kelly's mom and begin to compile some information.
Hi, I'm Kelly's mom. I'm not able to make today's evaluation, but I'm happy to answer any questions you have.
So you can ask questions in any of these areas, and we'll start with identifying family information. You're going to have different types of questions here. You have ones that are reflective that earns you points. You have ones that are acceptable. They're neutral. They do not impact your score at all. And then you also have ones that are rejected. Questions are going to be rejected if they are insensitive, if they are redundant, if they use medical jargon that the listener can't understand, or if they are not developmentally appropriate. So, question like, how old is Kelly? What grade is Kelly in? Well, that was already in our referral information, so that's just going to be acceptable.
Kelly is in the 2nd grade.
So again, not wrong, does not impact our score. Tell me about your family. Does Kelly have any siblings? That's going to be a reflective question.
Kelly is an only child.
Is there a family history of speech, language, learning, or reading delays? Again, a reflective question.
I've always had difficulty sounding out words, and my sister is dyslexic.
We can also ask Mom, what are your concerns? When I do this, I will have selected 3 reflective questions in a row. You're going to see a green bar appear at the bottom of the screen. That's going to be positive feedback, and we want to listen closely to Mom's answer.
Kelly is struggling in school. Reading and math are her most difficult subjects. Kelly has difficulty learning to sound out words, and she relies on her memory, which makes it difficult for her when reading and doing math problems. She loses interest quickly when she does not understand the material.
And now I would like for you to look up near case history, and you can see our progress meter is filled in a little bit, but we're going to ask some more reflective questions. I'm going to mute Mom so we can move through this quickly and watch the progress meter continue to fill in. In what areas does this concern seem to impact Kelly the most? Has anyone else expressed this concern? Has she ever received diagnostic or therapeutic services? Again, you see our green bar down here for our 3 reflective in a row, and you can see the progress meter is filling in. Let's ask a few more reflectives. Any complications during your pregnancy? Did she meet all her developmental milestones? Does she have a history of ear infections or hearing problems? So again, you see our progress meter gradually starting to fill up. But now we're going to ask some rejected questions. So Kelly's mom indicates that she just got separated. Asking Kelly's mom, why did you get separated? That's going to be an insensitive question. You're going to see a red bar appear at the bottom of the screen. So that lets us know that our question has been rejected. Mom says, do we really need to get into that now? Anyone in your family have a history of speech language learning or reading delays? Has anyone in your family ever been diagnosed with a reading disorder? These 2 questions are basically the same. When I click on the second one, I'm going to get the same response I got for the first one, and you're going to see a message that says avoid selecting redundant questions.
I've always had difficulty sounding out words, and my sister is dyslexic.
You can see that our progress meter has started to go down. If while I'm in language and literacy, I ask Kelly's mom, what is your type token ratio? Or what is Kelly's type token ratio? Here, I'm going to lose points for using medical jargon with a listener that wouldn't understand it.
I am not sure. I don't know what that is.
And there you can see we did lose some more points. Now, if you look over in your clipboard on the right-hand side, you'll see redirect 1, 2, and 3. That lets me know that I have missed 3 questions so far. Now, I can continue to complete this case and still reach a 90 or above. So I would continue going. But this just lets you monitor, the number of correct or incorrect questions that you have selected. From here, I can move on to collaborators. So I take the information in case history and I move to collaborators and I choose folks to speak with that would be appropriate for this case. Now, Kelly's mom indicates that she recently saw the school psychologist, so we'll start with him and hear what he has to say.
Hi, I'm the psychologist who evaluated Kelly. I sent her complete diagnostic report to your clipboard. I wasn't able to complete achievement testing. I recommend you include that in your evaluation.
So he gave us 2 clues. Number 1, he did not complete achievement testing. We need to remember to do that. Number 2, he said he sent us a diagnostic report and it's in our clipboard. So let's look over in the right-hand side. And there we see Kelly's psychologist evaluation report in the form of a PDF. It's going to be important for you to read those reports as many times. There will be information here that is not located anywhere else. Here we see that Kelly's cognitive abilities are actually in the average to high average range, but we also find out that she is having some attentional issues. So ADHD was diagnosed. Now, this diagnosis is not located anywhere else, again, underscoring the importance of taking a look at these reports and reading them very carefully. You also have the opportunity to interview your collaborators. Sometimes they're going to have more information for you. Other times they'll just say to read the report. You are not going to talk to all of these people. For example, Kelly's mom says she never received any kind of therapeutic services before, so the PT is going to be ruled out right there. So just basically be careful with the people that you select to collaborate with, and then you can certainly ask them more questions and try to avoid the rejected ones. Next, we'll take this information from our case history and our collaborators section, and we'll create a clinical hypothesis. So here, you're going to answer the question, what do you think may be impacting Kelly's literacy skills? So what underlying language problems may be impacting Kelly's literacy skills, and how are you going to assess her? And are there things that you need to rule out? So basically take all that information from the case history and collaborators section and create a hypothesis and also an action plan. The action plan will be what assessments you might administer when you get to the assessment section. So we'll save our hypothesis. And here we can see our progress meter is filled in. Now, Sydney K.
Okay, we're going to stop it right there, just so you get the idea of how the students move through those different case-based scenarios. So in our first level 1 field work in those first few weeks, we just kind of go over these 3 boxes here at the top, the case history, collaborators, and then hypothesis developing, thinking about goal formation and objectives to move this child into the proper developmental timeline. So we just kind of go over these 3, and then as the semester progresses, they'll complete all of the sections. So that is our SIME case. As I said, we do the part task trainers. We also utilize the learning mode for the first 4 or 5 weeks, and then we go into the assessment mode where the students will not get that feedback directly during the case, but at the very end, they'll get a summarization of their performance, and then they'll be able to go back and correct any of those challenging areas. And our goal really is for those students to be at that 90% success rate at the end of that field work. Our next virtual reality platform is Oculus. This is a virtual reality headset developed by Meta to run VR games and immersive experiences. Esses et al. This included 2 case studies where psychotherapists instructed participants to complete augmented VR tasks where they could see themselves and their surroundings in a mirrored format. Participants were evaluated pre and post intervention to evaluate upper limb motor function using the Fogelmeyer scale, and the second study used gains of motion and specifically shoulder range of motion, flexion, and abduction. And this was assessed by computer biometrics, and the results of this showed significant trends for greater upper limb motor improvement in the AR augmented reality group than in the other group. There's another study by Kim et al. With 28 participants with cognitive impairment following a stroke. Half were in the VR group with VR sessions and cognitive training, and the other were in a control group with only cognitive training. The VR group showed overall greater improvements with visual spatial performance and visual and verbal functioning. And you have to keep in mind that the Oculus can be overstimulating for some patients. So we need to assess this early and know that, we need to know what their balance is, and maybe have them sit instead of stand, for example. This is a picture of our Oculus system used in our neuro lab. So I've got a little video of our and the our neurology professor is actually in the room with me, kind of walking me through different things, but I'm actually in this video telling you what I'm seeing and doing as well, and what the students would be seeing and doing. If I can get it to play. I'm not sure it wants to play. Yeah, I'm not sure. It's not letting. Not wanting to play this one. So basically, I've got the Oculus on, and I'm moving items around in the virtual lab. And this is kind of the setting that we have students go through, is where they walk into a lab and there's different little toys they can play with. There's blocks they can stack, and they're all neon colored, and they can kind of move those around in the virtual room. And this is something we have patients, we would instruct patients to do as well, especially if there's indications such as deficits in bilateral coordination, reaching across the body to grab the different neon colored blocks and bring them over to a moving platform to their opposite side. And those are some of the things that I'm actually doing in this video. and explaining to you in real time as I'm doing them. There's also different devices in this lab, this virtual lab, and we call it our virtual classroom for the clients. But for the students, it's actually a virtual lab where they're learning how to train patients in this. But there's little things that they can pull on, like little fireworks and little slingshots and things they can do and manipulate from a bilateral standpoint, from a gripping standpoint, from connecting that central nervous system to the motor output in real time. So my apologies, that video did not work. This is an Oculus application, YouTube video post-stroke, and this is also something that we teach students to do and has been very beneficial. A few students that I've talked to on my midterm visits even said that they were using their VR application at their clinical site, doing a program very similar to this.
Alternately touch a bubble with your left and right. Good job. Perfect. Be careful and alternately touch a bubble with your awesome. Great. Be careful and alternately touch a bubble with your left. Great. Awesome. Good job. Pay attention and watch your right hand.
So yeah, that's our Oculus application post-stroke.
Oh.
Something we recently added to our psychosocial health and wellness fieldwork related to promoting sensitivity and awareness to others' perspectives in particular is the body swap platform. This is a platform that allows one to embody an avatar and role play from a mind-body approach. It uses customizable AI role plays, tailor assessments, and VR-powered immersive platforms. You can change the clinical setting that you're in on body swaps, and it provides a holistic experience to motivate and engage students in real time. And this concept of virtual body swapping involves users exchanging their avatars and perspectives with other users in the scenarios. And it just allows for that more unique experience to embody and kind of get a different perspective on what's happening in the situation. So there's a couple studies here. Fitzpatrick found that the intervention had positive effects on healthy participants, evidenced by a significant increase in self-compassion scores, a reduction in self-criticism scores, and an improvement in evaluating their own appearance. And another study reported increased awareness and attention to sensitive feelings when completing body swaps, including an improved self-compassion response, being intentional in communication, and even improving self-care practices that included mindful relaxation and other positive general self-care strategies. And we use it in our mental health group coursework and fieldwork labs to offer that realistic VR role-playing for managing difficult behaviors, conflict resolution, and promoting active listening techniques. So I kind of term this to our students as those soft skills that I want them to develop that are so important, especially when it comes, those transformative soft skills, especially when it comes to de-escalation and things like that. So let's hope this one works. This is one of the platforms. So we have individual little iPads set up in our simulation lab the students can use, and this is one of the scenarios on that body swaps application. And this one's not going to play either. So in this scenario, I can just walk you through this one. This is anger signals. So this is recognizing signals of anger. And this is actually a scenario where the OT student walks in during this consultation and the nurse is here, they're waiting on the doctor and they're waiting on you to come in. The husband is upset that the wife is waiting for the staff to arrive. And so then you're able in real time to look at signals of anger, like worsening, escalating, and then ways that you can de-escalate that. So you're given like little options throughout the body swap. You can actually swap with the nurse. You can swap with the doctor that walks in late. You can swap with the individual. And we tell students, swap with the individual that's getting angry. That way you're able to see maybe what are those elements that's causing that anger to rise up. You know, how many people have been in talked to him today? Is he right for being impatient because everybody's kind of left them kind of you know, hanging all weekend and they haven't seen anybody, or what's really causing this, and just kind of getting a different approach before you respond. So in this scenario, you see that you have identified how Joe is feeling and recognizing that something has happened to justify them, and it's helped him to feel listened to and understood. So you offered a good diffusing strategy to diffuse his anger, and then it'll give you feedback in real time to show you whether or not you're making good choices in the body swap. And what I'm hearing from students is that they like this a little bit better than potentially working with somebody like a standardized patient, one of our trained patients in the simulation lab. Instead of working with like a real person yelling at them, they have a computer where it's not so aggressive and it's not so harsh, that they're able to kind of understand that it's a virtual, and there's quick little choices and responses they can get and feedback with that as well. So our OT feedback on body swaps application, there are a few themes that we've noticed, and from a couple of years of using this, I'm sorry, a couple of semesters, years using this, it's only been 2 semesters. So we see improved teamwork, cultural sensitivity, students are better able, or they better represented abilities, show better represented abilities to manage those difficult behaviors. They usually report better empathy and active listening. And this is just, again, from those end of the semester evaluations, talking with patients. They feel more empathetic for the different caregivers and patients that they're encountering in body swaps. And then they're also learning how their communication is either contributing or contaminating effectively or ineffectively in those different scenarios. And the last VR application we use here at NKU is the Animage table. This is the digital life-size table that features real human bodies in digital forms, allowing for dissection, freezing, and identification of body parts, and real-time digital exploration of tissue physiology. It allows students to practice procedures on real human bodies without the need for physical cadavers. Students and other trainees can visualize and interact with anatomical structures in real time during procedures. And there are specialized procedures built into the Animage table, including volumetric dissection, ultrasound, tissue removal, and muscular movements. And some of those might look like, especially in our neuro labs, our neuro professor will pull everything away from the virtual cadaver, except for the central nervous system, and show those vital lines of motor connections. And then also, when we do our rehab and medical clinical signs and symptoms course, this looks like, you know, if we're talking about that cardiovascular functioning, same thing. We pull all the other systems away. You have the heart beating and the blood flowing through the venous system in real time. So how we use it in medical conditions to identify vascular and neurological structures, as well in orthopedics to look at those functional movements identify joints, bones, and neuromuscular tissues and movements and related to specific conditions. For instance, you can move the upper limb through external rotation, stopping and identifying those core rotator cuff muscles and tendons involved in an impingement syndrome, for instance. And I don't know that my other videos in play, so I'm not sure this one will play. And I might just have to end the slideshow, might be the best way. And let me just go back to open it up. And let me try this. So maybe I can open it here and you can see it that way. And it's just not wanting to play. Okay. So in this picture, this is an actual picture of the cadaver. It's an actual cadaver, but it's on a virtual platform. And then this is a picture on the right side here of the rotator or the shoulder muscles, excuse me, moving the arm into abduction. And you can see the simulation faculty here narrowing down those movements. But you can, he was showing you in this video how you remove the skin, the superficial tissue, and then you have the fascia tissue, and then you remove it again, and then you have the muscular tissue, and then you get the idea. So I really apologize. These videos are not wanting to come on. I thought maybe ending the slideshow would work, but it did not. But so here he's narrowing down the central nervous system and different brainstem functions. And then in this one, he's showing you the cardiovascular process. So he's showing you the arterial and venous lines of flow. And go back to the slideshow. You can see that. And then other notable devices are the Sabo platforms. And this offers a mobile arm support with a VR component. So this is something that we've started to utilize in our neuro coursework. We just received one of these mobile arm devices from Sabo. And we use it along with our bit screen for neurology. So it's kind of similar to what they're doing here, where he's, excuse me, where he is reaching into the refrigerator in real time using his affected extremity. So those are up and coming devices from a virtual reality standpoint, where you can take the patient into their rooms to retrieve clothing, such as the one here on the right. And this is the Sabo VR virtual ADL rehabilitation. And describe one of them. Excuse me a minute. And this just so you can see a little bit better. That could be the kind of application that everything is any kind of factors that you could potentially have. There's a lot of opportunity there to individualize it for your patients. And then this is another VR platform that we have seen very helpful, especially with the autism spectrum, within the autism spectrum. This particular program is for the neurodivergent intervention, but we have seen it be very helpful out on some of our level 2s as it relates to more of those profound autism diagnosis. I'm just going to show you this little video on this Florio VR.
Here's an example of Florio VR. When the devices are paired, the monitor can see the learner's view between these two green lines, as well as some of the area outside of the view of the learner. Banner language is delivered here to provide guidance to the monitor. In this lesson, the monitor has some simple controls used to direct the lesson. This learning card is called Emma is Pointing. In this lesson, the monitor is able to choose an animal. When the learner looks at the safari guide, Emma will point to that animal. Banner shows a speak icon when displaying suggested language that the monitor may say to the learner. The learner looks at the animal and a reward animation is activated along with a star particle effect and a reward chime. The Florio system allows us to capitalize on gaze fixation and deliver the stimulus only at the appropriate time. If a target animal is chosen, but the learner is not looking at Emma will call and wave to the learner. As soon as the learner looks at Emma, she points to the target animal, in this case, the parrot, who is on the tree in back of the learner.
Okay, and that's Florio. Or Floria. Or Florio. I've heard it called a few different things. But everybody calls it helpful if you're working with that population. Here's just another little video, and this is
a harmony forest.
And this
Let's
is
meet
Harmony Forest, and this is basically their little interactive setting for social engagement. And this is only 30 seconds. So
Friends who play here.
My name is Myra. My name is Iona.
My name is Alejandro.
I can't wait to see it.
Together they will make a magic dragon. And all by taking turns and being great friends. Here I go.
So then that student is able to congratulate their peer and able to talk to their peers in real time. You're able to take the wand from one of your peers, so they have to socially interact if they want to turn at making that dragon. So that has been spoken about by some of our students in those same classrooms, talking about how beneficial that is, especially one-on-one with a student in a quiet setting. So some final tips and takeaways on this presentation. Virtual reality can impact student motivation and engagement, as well as our clients' engagement and motivation. That's really what we kind of focus in on with the students is, yes, we know this motivates you to learn. We know this engages you in a different way, more so than a textbook ever could. But we want you to take these lessons and these opportunities to your clients. So we don't want them to stop here in our program. We want you to take this out into your intervention. And then cases presented can be refined, offering case-based and student-centered learning. Learners can move at their own pace, and the evidence supports the use of these in OT curriculum and the clinic, promoting best practices for the profession. So I just want to thank you for your time. And any questions that you might have, please email me. My email there is in red under my name. I would be happy to answer any questions that you might have in regards to using virtual reality in your clinical site or in your clinical setting, and or in an educational setting. Or if you're a fieldwork educator and you have a student coming and you want to implement some of this VR, I would be happy to answer questions. A big part of what inhibits some settings from using VR is obviously the cost. So I know there's different devices out there. Some are affordable and some are not. Just kind of researching some of those and what might fit best in your setting would be my first recommendation. So the last few slides are just the references that were utilized to complete this presentation. So if you have any questions on those. And then this final one is the article to review. And then there's 5 multiple choice questions attached to the presentation as well to direct learning. So I hope you've enjoyed this presentation, and please reach out to me with any questions. Thank you.